Good morning to all of you. Good morning again, in your case, Professor Dillon.
Morning.
Can you hear me, Dr. McLean?
Yes, I can.
Good. And you can see me?
Yes, I can. Thank you.
Good. Then we're ready to begin. Let me explain the arrangements so that you all know. You're talking not just to the audience immediately in front of you, but to those who are sitting in a breakout room beyond this room, and who are watching on live stream or YouTube. The total number will be in the region of 3 figures somewhere, can't say exactly. To your left, there are lawyers who represent various interests in the inquiry. On the back left, there are representatives of the press. So that's your audience, apart from me, of course. And in a moment or two, Ms. Fraser-Butlin will ask you the questions. But first, Mary will ask each of you in turn to give your respective oaths.
Please state your full name.
I'm Professor Graham Russell Foster.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Professor John Francis Dillon.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Dr. Brendan Healy.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Dr. Joanne McLean.
Thank you. And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Yes.
Thank you. Professor Foster, if we can start with you. You are NHS England's National Clinical Lead for Hepatitis C and National Clinical Chair for the NHS England's Hepatitis C Elimination Programme.
That's correct.
Could you tell us what those roles involve?
So I was appointed to the national roles in around 2015. My main focus is providing clinical advice and support to the NHS England Hepatitis C Elimination team. So that will involve attending the appropriate meetings, providing advice and guidance, recommending strategies, and essentially liaising with clinical colleagues, trying to make sure that the clinical opinions are heard at the commissioning level.
And you discuss in your statement the Hepatitis C Elimination Programme, and you say there that the programme has been funded by NHS England, but that the pharmaceutical companies who sell the drugs for treating hepatitis C also have a contractual obligation to invest in elimination initiatives.
That's correct.
Can you explain for us what that means, that pharmaceutical companies what are they involved in?
This goes to a large-scale procurement that initiated about 5 years ago, when we recognised that the pharmaceutical companies had skill sets that could be useful to us in an elimination programme. And we realised that if we collaborated with the pharmaceutical industry, we could achieve more than we could in isolation. So we put forward a procurement programme, and the programme said the drug companies had to put their best price forward, and they had to put forward elimination initiatives. And they had to agree to fund those initiatives. All of those were then scored in a very complex legalistic procurement process that led to an awarding of market share. So each of the drug companies is allowed to sell no more than X% of their particular product. So what that means in reality is that instead of a drug representative coming into my clinic and saying, I want you to use drug X because it's better than drug Y, they come into the clinic and say, we want to find more patients. So we have the bizarre situation sometimes where a drug company will recommend a competitor's product so that the patient can get better treatment, because they know if they're treated with a competitor's products, there will be a corresponding increase in their performance because the market share is fixed. I think that's been a great success. It took a year or two to bed in. It was a very difficult working relationship to begin with, but it means that everyone is working on finding people with hepatitis C and getting them on treatment as quickly as we can.
And in terms of those initiatives, does this mean that pharmaceutical companies themselves are undertaking initiatives to find people, or that they're funding NHS England initiatives?
It's a combination. So there are, for example, direct funding from pharmaceutical companies. They will buy, for example, point-of-care testing machines, and they will install them in places. They will put them in places where NHS England recommends. There are areas where they clearly can't go. They can't have access to patient information, they can't have access to GP records, etc., and there they would work through us. So each initiative is a joint approach with appropriate funding streams, appropriate governance streams, depending on where the particular strengths lie. So to give you an example of where this is able to expedite performance is in treating people in injecting drug services, because injecting drug services are not commissioned by NHS England, they're commissioned by local authorities. So NHS England has no authority. So I cannot go into an injection drug service supplier, but a pharmaceutical company can, and they can make changes, recommendations. I talked a moment ago about the point-of-care testing machines. To get a point-of-care testing machine through the NHS requires a fairly lengthy bureaucratic process, validating, supporting, a procurement process. The pharmaceutical company can access those machines very quickly and have them in place within weeks rather than months. So we try and use their skills where appropriate.
And when you spoke a moment ago about data that pharmaceutical companies couldn't access, so they went through NHS England, just to be clear, I think what you mean is that they would fund somebody in NHS England to deal with that data, rather than that any of that data would ever go to the pharmaceutical companies.
Pharmaceutical companies under no circumstances can ever have access to any patient's individual protected data. What they do get are aggregate figures to say, this month we have treated X hundred patients. So they never get patient level data. Indeed, commissioners at NHS England, as an NHS commissioner, are not allowed to see individual patient data. Commissioning is patient agnostic and anonymised from start to finish.
You've talked in your statement about there being 3 phases to the elimination programme. Phase 1 relating to the provision of oral therapies. Phase 2 focused on particular at-risk groups. What can you tell us about what phase 2 involved?
So if I set the stage perhaps with the constraints that we commission under, our first use is always to look at what resource we are going to deploy on a particular programme. And resource is not just about money, increasingly it's about people and skills. So we're very aware that if, for example, we ask primary care physicians to do a series of tests for hepatitis C, they will not be doing a series of tasks in something else. So if they're testing everybody for hepatitis C, they are going to have to stop testing for diabetes or cardiovascular disease. So in a fixed resource environment, which is where we work, we try and weigh up where we're going to get maximum advantage, and we need to be very careful that we don't have inappropriate consequences and reduce access to services in other areas. So the first constraint we have is, in crude terms, how much bang do we get for our buck? Where can we get best advantage? The second constraint is equity, and the NHS England does not distinguish by mode of acquisition of disease. We focus on priority and need. And we appreciate that individuals may have different views, but our focus is always to try and provide an equitable, equal service, regardless of how people contracted their particular problem. So within those constraints, when we started our programme, we had very limited access to drugs. The drugs were very expensive, and there was a cap on the number of treatments that we could give. And to begin with, we didn't know how effective they would be in the real world. So we started our focus on people with decompensated cirrhosis, very advanced liver disease, and then very quickly we moved to an understanding that the treatment was safe, as effective in the real world as it was in the clinical trials, and we started to negotiate a much better deal. So at that stage, we set up a Go for hepatitis C elimination program. The first thing we did was to institute a sort of facilitatory treatment atmosphere. We did that by dividing the country into networks, operational delivery networks, and each of those networks was given treatment targets, and those were challenging treatment targets. I had a series of emails from people saying we really can't find all of these. And if people didn't hit those treatment targets, there was a very significant financial penalty. And when I say significant, in the millions of pounds terms for some trusts. So we incentivised people to go out and find patients. We then put a per treated patient fee. So every patient treated gets a £500 fee from NHS England. So that's an environment that really incentivises and drives people to get as many hepatitis C patients as they possibly can. It has led trusts and organisations to invest in hepatitis C elimination. So that set the soil for the initiatives. We then set up a whole variety of initiatives focusing on different patient populations. I think the ones that are of main interest to the inquiry are those looking for people who might have been infected by contaminated blood or blood products. The main focus to begin with was looking at people who were known to have hepatitis C, who had a diagnosis. And we knew there were a lot of people with positive test results that hadn't been offered treatment, hadn't been properly supported. So we wanted to get all of those patients. We made it a condition of the networks that they had links to their local virology service, so they would have access to all the previous tests. And with our colleagues at Public Health England, we had a re-engagement exercise. And that re-engagement exercise looked at all of the positive hepatitis C tests. We cross-referenced to those that we knew had been treated and removed those. And that gave us a list of about 50,000 people who we contacted individually to check their hepatitis C status and offer treatment. So that re-engagement exercise found, we hope, a large proportion of the people with hepatitis C. As I mentioned in my statement, we've got a number of other initiatives that are ongoing, and I'm happy to go into those now or defer as you prefer.
If we can just pause a moment on the exercise of identifying those people who had a previous positive test but for various reasons hadn't been treated. You said you ended up with a list of about 50,000. Do you have any figures, and you may need to provide them later, any figures of how successful that exercise was?
So unfortunately, as the programme was being evaluated and Public Health England had an audit and assessment of that, the coronavirus pandemic struck and that diverted resource. So the audit has not been completed. The preliminary data that I've seen suggests that about 10% of the people who were on that list had a positive hepatitis C test and went on to treatment. So it was about 1 in 10 were caught and treated, but I don't have a denominator for that, I'm afraid.
Could you help us then what the position was in relation to the other 9 out of 10?
So a lot of people had false positive tests. A large proportion of people had been treated. We never had records of people treated in the interferon era. We only have records of people treated in the oral medication. So a lot of people have been treated. A surprisingly large number of people had access treatment in other ways. And outside the NHS, there are ways of purchasing the oral antiviral therapies, and a significant number of people, quite a surprisingly large number of people, had gone to websites, purchased treatments, taken it themselves. Quite a lot of people of Pakistani heritage had gone back to Pakistan and bought treatment there where it was cheap. And interestingly, they were very keen to engage with us to test that the treatment had actually worked. So it was a whole variety of different reasons for people who hadn't been, who tested negative on retesting.
And again, this may be something you need to tell us at a later date, but of that 50,000, roughly how many of them could you not find? The inquiry's heard evidence about previous look-back exercises where there's been difficulties finding patients.
I would have to revert to my Public Health England colleagues and their audit to give you that detailed data, but During the process, we had NHS numbers, GP records, and Public Health England were able to give us an active phone number that was on the GP records. So we'd already sieved out patients who had no obvious contact point. A proportion clearly weren't contactable, and those that weren't contactable, we wrote to the GP and said, we have tried to contact this patient. Next time this patient attends your surgery, can you please arrange a hepatitis C test? So I don't unfortunately have the data, and I suspect that because the audit was never completed, I rather suspect that data won't be readily available.
In terms of the other initiatives that were taken in phase 2, they were primarily focused on particular risk groups, weren't they?
So as we moved into an expansion of the programme, one of our priorities was people who were transmitting the virus, because clearly if we're going to eliminate hepatitis C, we need to stop the virus transmitting. And the people who were transmitting the virus were people who were disengaged from healthcare services, and treatment provision in needle exchange centres, people who were injecting drugs, were very poor at that time. So one of our major priorities was to get treatment into injecting drug services, make sure the homeless populations, the disadvantaged populations had access to therapy so they would not transmit to others. And that was run in parallel with the GP screening, the awareness raising in primary care, and as I'm sure we'll come on to in a moment, our GP track and trace tool.
Which we will come to. But before we leave phase 2, I think there was also some work done in relation to patients known to services to double check their status in relation to patients who with haemophilia or who who also had HIV infection, and to check that whether there was co-infection.
We worked the patients who were in haemophilia services. We have, as you know, testing regimes for people in haemophilia services. We incentivise people to go and find those people early on and get them offered treatment as we expanded. It sounds rather facile to say, but in a way they are probably the easiest patients to find. They're in services, heavily engaged in healthcare, and treatment, once we established that it was efficacious and widely available, was very easy to deploy. So I think that we have probably offered antiviral therapy to all patients in haemophilia services, and we work with haemophilia services to confirm that.
And then we come on to phase 3. You've described phase 3 as identifying people at risk of infection who haven't been tested. And in your statement, you've identified 6 measures that are being implemented, if we can take them in turn. First of all, work to encourage testing in primary care. What has that involved?
So we've written a number of articles to primary care colleagues, had a number of primary care advisory boards. We have, it's fair to say, found our primary care colleagues distracted by the coronavirus pandemic, and we have not had the engagement that we would have wished. We've just recruiting, as in put out job adverts for what we call GP champions, and we're going to pilot those in London. So we're going to appoint a small number of general practitioners with a particular interest in hepatitis C who will encourage their colleagues to engage with us. They will also, I hope, undertake some of the basic chores of going through general practice lists, identifying patients at risks. So I hope the GP practice champion model will work. It worked very well in HIV, increasing testing rates. So we'll see if that works in London, and if that is successful, then we'll roll it out nationally.
Secondly, you've talked about an online testing portal. Could you tell us what the aim of that portal is?
There are really several groups of patients that are not accessing proper testing at the moment. There's a group of people who have risk factors that they would prefer not to divulge. There's a group of people who find it inconvenient to go to their primary care physician. And there's a group of people who are worried by stigma of hepatitis C. And all of those 3 groups are areas that we want to target. So the intention is to set up a website, and we are going through the procurement process now that's been completed. A preferred bidder has been selected, and we're working with them on the design of the website, and hopefully that will be live before Christmas. So anyone will be able to go into the website. In the website, they will land on an appropriate landing page. So if you've been referred by your primary care physician, you will go to a page that says your doctor has recommended, here's what you do. If you've gone to it from an Urdu or a foreign language, then you'll land on a foreign language site. If you've gone it as an interested member of the public, you'll be directed to a page that says you might need a hep C test if. So the idea is we will have different landing pages, and those are being worked through at the moment, and how many we will end up with and what they'll look like, I couldn't tell you at the moment. But people will then go in, request a test. They will be sent through the post, a needle stick lancet and a tube. They will put the sample in the tube and post it off. That's worked very successfully in HIV testing and sexual health, as well as coronavirus testing, so we believe that will be acceptable to people. And we've done some focus group work to see whether patients prefer an oral swab or a finger prick swab. When the result is obtained by the laboratory, if it's negative, the patient will be contacted directly to say you are hepatitis C negative. If it's positive, the result will be passed on to the local hepatitis C treating centre, who will contact the patient directly. We don't want patients with a positive test getting a phone call that says you've got hepatitis C, you'll have to do something about it. We don't want them getting an email or a text. We want them supported by someone who will say, you've got hepatitis C, I'm a nurse who will help you treat it, here's what you need to do, and here's what will happen. So we want to make sure they have counselling and support. I hope that will be live before Christmas. Whether it'll be live in its entirety or whether it'll be a section of it, I can't tell you at the moment, but the hope is that that will be up and running in its full form by early next year.
And you spoke a moment ago about there being foreign language pages as well. When the result is provided, if it's a positive result, to the local treatment centre, what provision will there be to deal with those language or, more significantly, sometimes the cultural barriers that somebody faces in even engaging with the treatment centre?
We're very aware of the high prevalence of hepatitis C in some of our immigrant communities. I have particular interest in the Pakistani community and run some work out in Pakistan. So we have appropriate language speakers. We also have peers with lived experience of hepatitis C from those countries who can talk to the individuals in the appropriate language. The main languages we're looking at are the Eastern European and Urdu speaking.
Your third measure that you deal with is work being done in introducing testing in emergency departments. What can you tell us about that?
So this is now live in London, and everyone who goes into a NHS emergency department in London will see a poster that says, in this department we test everyone for viral hepatitis and HIV. If they have a blood sample taken, the treating physician will tick a single box, and that single box will trigger a blood request form for HIV, hepatitis B and hepatitis C tests. Those will be processed in the laboratory, and the patients who are positive will be informed. And there are information leaflets that say, no news is good news. If we don't phone you, you do not have any of these infections. So we will contact patients from the centre, and there's a triage process whereby patients are contacted after an appointment. If they don't respond to that, they're contacted a second time. If they don't respond to that, then their GP is informed and their notes are flagged. We are now running throughout London. I have to say that we have found huge numbers of hepatitis B, several hundred per month, so a very large number of hepatitis B patients in London that were undiagnosed. Relatively few hepatitis C patients, in the tens of patients per month, of which a large proportion are already known to services, and a handful of patients with HIV. In fact, the HIV and the hepatitis C numbers are roughly similar at the moment. Now, all of those numbers come with a caveat. These are very early days. The data streams are not as robust as they need to be, and we haven't yet had the first full detailed report, but that's the trend. It will be rolled out, we hope, in Brighton and Blackpool very shortly. We're talking about rolling it out in Manchester, and Birmingham is on a hit list. So the hope is that across the country, we will have a period where everyone in an emergency department is tested. That'll give us, of course, a cohort of patients who need treatment and care, and we have strategies to look after them. But it will also give us a very good idea on what we're missing. And as I mentioned at the beginning, we're getting to a law of diminishing returns. We want to make sure we're investing our resource, our people, in the right places. And what I don't know is what I don't know. Where are the people I don't know about hiding? Where are there little pockets of hepatitis C infection that I'm not hitting with our current strategies? And a random testing in people turning up in emergency departments will help give us that data, and that will then inform our future strategies.
And just to be clear, it's everyone who attends the accident and emergency and has a blood test.
A blood test, exactly, yes.
But there's no requirement for the doctor to think there's a risk factor here. It's simply a blood test and it gets ticked.
If I go into casualty and stick my arm out, they'll test me.
Fourthly, you've mentioned the Liverpool surplus blood testing. What does that involve?
So the proposal here, and we're still working our way through this, unfortunately, is to take 17,000 blood samples that have been tested for other reasons. So blood samples from GPs, blood samples from hospitals, surplus samples in the laboratory, run those through a hepatitis C testing program. So again, that's looking at a population of patients that don't have any obvious risk factors, and again, it will feed into the models we're generating of where are the missing patients that we're missing. I have to say it's stumbling along a little bit at the moment. There's quite a lot of IG issues, quite a lot of laboratory capacity, but I hope that we can get that launched. If not, then we will have to rethink. But I think using extra blood samples that would otherwise have been discarded to do batch runs of hepatitis C tests to give us an insight into what we're missing is certainly a direction we want to go in.
And then we come to the development of the case-finding search tool. How will this tool operate?
So this is a tool that we've developed in coordination with MSD. Again, this is one of the advantages of the pharma collaboration. They've done quite a lot of work with GP search tools looking for patients with risk factors. We've developed a tool that allows a general practitioner to screen their patient notes and identify risk factors for hepatitis C. The plan is that we will run the tool on a GP practice, identify people at risk, and then test all of those people. We want to stratify the risks and stratify the testing. So for people with a very high risk, and that will probably include people with a known blood transfusion in the at-risk periods, people with a known positive test, people with active injection drug use, etc., those will be contacted directly for a test by a phone call. For people with an intermediate risk, the idea is that we will navigate them to the website, and we will also at the same time flag the general practitioner notes so that when they come in for an incidental event. And the third group will be people at lower risk who we will simply refer to the website. We'd hoped that it would be up and running by now, but it has been slow to implement. And what we've been working on is trying to define what are those risk categories. If we were to test a large group of people with risk factors A, B, and C, how many would be positive? Whilst we know from our preliminary studies that 6 to 7% of GP practices patients flag up positive on the algorithm, so that would mean huge numbers of tests. We don't want to go out and test all of those patients just for hepatitis C. A lot of them have the risk factor is abnormal liver function test, so they may have other causes of liver disease. And it seems silly to go and test people today for hepatitis C, go back next week when we're doing a hep B. We want to do them once. So we're looking at ways that we can automate that and link into a more general liver screen. I think we are probably going to go, if we can, to a national overview of this. Our attempts to persuade our primary care colleagues to run the tool and work with it have been disappointing. They've got a lot of pressures on at the moment. So we're working with NHS Digital, and the idea is we will do this across the country. So at central office, we'll go through every patient's record throughout the country, flag up those with risk factors for hepatitis C, and then those will be contacted electronically or whatever. The governance, the information rules about handling data in that way are extraordinarily complex, and we haven't yet solved it. I think it's fair to say that we have an absolute commitment to screen GP records and pull out those patients who are at risk. And obviously what risk factors we find will be informed by the other studies that we're doing, the casualty studies, the look-back studies.
And you said there that one of the risk factors that would put someone into the high-risk category would be a transfusion in the relevant period.
That's right, but we are very aware that because of the paper records at that time and the electronic transfer, that transfer may be incomplete, which is why we're looking at other markers, abnormal liver function tests, and other risk factors. It's difficult to know where to look until we've done the preliminary screens that would give us more information on the risk factors, but identifying a high-risk cohort is an absolute priority for us.
You preempted my question, which related to the difficulties of a lack of evidence in medical records. So in terms of that, are you building into the risk factors at this stage anything that suggests if there's been major trauma, even though there's not a transfusion noted, that would count, or perhaps evidence of a woman having given birth in a particular time frame?
We do. It's a very good question, and at the moment we don't include major trauma and we don't include previous pregnancy. Clearly, if that were to come up as a potential flag, then we would incorporate it, and I'm sure we'll come on to in a moment a 100,000 patient study that, again, we hope will inform. So the challenge we're trying to face is not overburdening primary care colleagues but not missing anyone. And that is the tension that we're constantly running. It's also important to bear in mind that people very quickly get fatigued if they're doing tests and not getting positive results. So we did a large-scale study looking at hepatitis C in people of Pakistani heritage, and it was a research project, but very quickly GPs were saying, we've tested 100 and found nothing, this is a waste of our time. And of course that is a problem if you are looking for an uncommon condition and doing a lot of tests that come back negative. Healthcare professionals disengage and realise that it's a waste of their time. So we need to be very careful into how we manage this, how we sell this to our primary care colleagues, that it is worthwhile if they're testing a lot of people and finding very few. So it's this constant tension between investing time and resource and mission fatigue and finding numbers of patients. And we have to try and find a way around that. And our policy at the moment is to get the data that will allow us to have a very strategic approach to this, getting the maximum return on our testing approach.
I've just had a message from our stenographers asking if we both could speak a little more slowly, because they are trying to take a full note of our conversation. I think we've both got so engaged with it, we've forgotten about the stenographers.
My apologies for my pace.
In terms of engaging with your primary care colleagues, perhaps this is something we'll come back as a full panel if we may, but in relation to one particular aspect, do you agree that to some extent the flagging approach will only work if the significance of that flag is fully understood by the GPs?
Very much so. We have to work with our primary care colleagues. Primary care colleagues quite rightly say that if while you're there testing were to take place on every patient, they would spend the entire consultation doing the while you've got the patient, do their blood pressure, their diabetes, mention the cervical screen. Sorry, I'm speeding. But GPs are being asked to do large amounts of primary prevention, and every extra test means that something else has to be reduced. And you're quite right that we have to work in partnership, and we have to be sure that we're making good use of their skills.
And what work has been done or is planned to be done to ensure that primary care colleagues are equipped to deal with patients and have that understanding of hepatitis C?
We've had a number of focus groups with primary care colleagues. We've had a number of education sessions. We've had a number of lecture sessions, not all of which I have to say have been very well attended. So our strategy going forward is to use the GP champion model. And the reason for doing that is it's been very successful in HIV. So using GPs who believe in the value of hepatitis C testing, persuade their colleagues, is, we think, more likely to be successful than having myself or one of my many esteemed colleagues banging our particular drum. So we think we will subvert from within.
The final measure you've noted is research to identify prevalence in those who wouldn't be identified by the case finding search tool. Can you tell us about that?
So this is a programme of work we've commissioned from the University of Bristol and Matt Hickman's group, who've done a lot of work in primary care. We will be going out to some 70, 80 primary care practices, going through randomly picking patients over the age of 40 and sending them through the post an oral swab. So you wipe the inside of your mouth, send it back, and that will give a hepatitis C test result. The patient will then be contacted if they're infected, obviously, and offered treatment. And we will then look at how many of those patients would have been identified by the MSD search tool, how many would have been identified by other flags on their notes, and how many would have been missed. So the idea is to look at the unknown unknowns. We're hoping from the 100,000 that we will get at least 10 to 15,000 returns. We know that there's a poor return rate. I can tell you that the last meeting I had, which was a few weeks ago, we had over 10,000 samples returned. At that stage, the first few thousand had been tested and a single antibody positive case had been identified and was working through. I haven't heard of any more positive cases in the remaining 5,000. So at the moment, we're looking at a rate of about 1 per 5,000, 1 per 10,000 people who have no obvious risk factors. So the hope is, again, that combining that data with the emergency department data, with the Liverpool 17,000 surplus samples data, will give us an idea of what we're missing. because my challenge, as I said right at the beginning, is how do I deploy the resource in the most effective way? Who am I going to miss? I really don't want to stop the hepatitis C programme until we've got everyone who wants to be found. And we all accept there are people who do not wish to be tested, and they're perfectly free to do so. And there will be people who test positive who do not want treatment, and they're perfectly free to do so. So we need to strike the balance between pestering people and informing them. I don't want to stop too early, but equally, in a very resource-stretched service, I don't want to take money away from testing for hepatitis B, where we have huge numbers of people to find, and waste my time looking for people who aren't there. So it's finding the sweet spot between an appropriate delivery of treatment, an appropriate testing strategy that uses the resources widely. And as I say, it really isn't for once about the money, it's about the time and the opportunities to primary care. And everything that we do for hepatitis C has an opportunity cost for something else. So we're trying to get the data to allow us to make an informed decision.
And you've said in your, but before we get there, once that research is complete, particularly the Bristol research and the case study, case search tool, what do you anticipate the next steps would then be?
I think there are three possibilities. The first is that the rate is very low, in which case we will congratulate ourselves, celebrate, and think about where are the tiny pockets left. I don't think England universally is close to elimination. I think there are parts that are very close to elimination. So it may be that there's very little left to be done, and that would be very good news. It may be that there's a very large number of people in a particular group. And clearly, if, for example, we find that, to take your pregnancy-associated transfusion group, if we find that women who gave birth 30 to 40 years ago have a surprisingly high risk of hepatitis C, then we could organise a targeted case-finding initiative, perhaps with a targeted publicity campaign that would pull in that particular risk group. The third possibility is that we will find very large numbers across the board, that we're further away from elimination than we think. And if that's the case, then we will need to think again about some form of near-global testing. My personal view would be that that global testing would be best delivered as part of a liver health screen. I don't really want to go and test people for hepatitis C and then go back next year, do their diabetes and their other tests of liver disease. I'd rather do a liver health screen once and make sure that patients are properly reassured. So I think those are the three possible outcomes, and we'll make decisions, obviously, as the data comes through. All the data, important to say, of course, will be published. This will all be public domain data. It'll be published in peer-reviewed journals. NHS England will make it available as press releases. So this will be a public consultation. And clearly, if there's a very strong feeling from the general public that we should be doing less or more, then we take that into account.
And in your statement, you've expressed a view that there are probably not many more individuals who've been infected with hepatitis C by blood or blood products who've not yet been identified. Can you explain why that is your view?
So several reasons underlying that. The first is I run a big clinical practice in the northeast of London, and I haven't seen a patient who has been infected by blood or blood products who hasn't been diagnosed for many, many years now. And that tends to be the view of my colleagues. So we're not seeing many people coming forward. I'm very much aware that Rachel Holford from the Hepatitis C Trust tells me that they have a regular stream of phone calls, which is clearly a matter of concern. But if we look at the numbers, the inquiry, as you know, produced a detailed review of the likely numbers. And if I quote, the mean number was 2,700 people chronically infected was still alive. In the English treatment database, we have 3,498 people treated.
Could you just pause there to allow us just to put the table up from the statistics
Yes,
report
sir.
so that people can follow the numbers? The reference is EXPG 5049, and it's page 54, which is the table I think, Professor Foster, you're referring to. It's page 50 of the physical copy, if anyone is using the physical book, 54 on the electronic version. Thank you. If we can just zoom into the table so we can see it. There we go. Professor Foster, you were saying.
I'm not sure.
You were looking at the column which is chronically infected survived to end of 2019, I think, which at the bottom, total UK,
yes,
gives
sorry.
a figure of 2,700.
I have him. Yes, so as you correctly say, thank you, 2,700 is the total UK estimate.
With a
When-
range of 3,910 2,050.
Exactly. So there are clearly a lot of assumptions and estimates in this that the authors made very clear. What we know from the NHS England Treatment Registry, we ask people to record all the treatments that they administer, and there are financial penalties if they don't. So they are asked to record a risk factor of infected by receipt of contaminated blood or blood products. What we don't do is distinguish whether that was administered in the UK or abroad. So there may be some increase. We also have it as patient thoughts. So it may be that patients believe they might have had a transfusion and report that as their risk factor when in fact it's different. So the data we have comes with caveats to it. But even allowing for the caveats, in England I can tell you 3,498 people, when I last looked at the registry download, which was a few months ago, had been infected in that way. So the total number of patients that we have treated in England is significantly greater than the total number estimated to be alive within the United Kingdom. So that gives me some degree of confidence that we are close to finding and treating all of those patients infected in that way. But as I hope I've made clear, we're not sufficiently arrogant to say we've got them all, because there will always be people we miss. I think we have a reasonable strategy to try and fill the gaps. And I think all of the different studies that we've unveiled will give us confidence to say whether we are close to finding everybody or not.
And as you've said, and the inquiry has heard evidence from the Hepatitis C Trust in relation to as you described, a fairly steady stream of people who have recently been diagnosed with hepatitis C and indicate that their risk factor is blood or blood products.
I'm absolutely sure there are people out there. Tragically, we will never manage to find everybody, no matter how hard we try. The question is, how many are we missing, and what is the opportunity cost of finding those people? If I put all my resources on testing everyone for hepatitis C, then other tests will not be done. And that is the challenge that we're trying to face. How do we make best use of the human resources that we have to minimise the harm to people at large? And I'm very cognizant of our obligation to do all that we possibly can to find everyone who has been infected. Whatever the mode of infection, we want them found and we want them treated.
And is it right then that the search finding tool and the research by Bristol will also assist you in assessing whether there is a cohort that are being missed in terms of those infected by blood or blood products?
Absolutely. One of the driving factors behind the Bristol study was to answer exactly that question. There are two cohorts that I worry about: people who dabble with illegal drugs and have moved on in their lives and don't want to declare it, and people who are infected by blood and blood products who don't have clinical records or indeed a memory of it. And I'm very aware that people will be infected by blood transfused during operations when they didn't realise they'd had a transfusion. So those are the two big unknown unknowns at the moment, and we're putting a lot of effort into finding out how many fit into those different categories.
Thank you. That table can come down. Before I move to the others on the panel and discuss the similar questions, there are a couple of matters that arose in your statement on different points that I've been asked to ask you about. In terms of the phase 1 of the strategy and the direct acting antivirals, was any consideration given to early access to those drugs for the infected blood cohort?
We discussed this at great length, and the decision that we reached was that it would be inappropriate to treat patients with milder disease because of the mode of acquisition rather than patients with more severe disease. At that time, we had very limited access to the treatments. There was a fixed number of treatments. We had a large number of people with advanced liver disease who were likely to die, and our initial priority was to treat people who were likely to die within the next 12 months. We then extended to people who were at significant risk of harm, patients with cirrhosis, patients with significant mental health problems from hepatitis C, and we recognised at the beginning that some people with hepatitis C have their lives ruined by the mere presence of the infection, and they will not be able to move on with their lives until they've cleared the infection. And we recognised that that was a reason for prioritising patients. We recognised that mothers who were wanting to get pregnant may well want to be clear of the virus, so we allowed that to be a priority. So we tried to cover all possibilities. We were specifically asked whether or not we would consider prioritising patients by mode of acquisition, and we decided that given the National Health Service has never prioritised any treatment by mode of acquisition, given that it would be inappropriate to treat people with mild disease whilst people at risk of dying were left untreated, we felt that was inappropriate, so we chose not to do so. And that was our very strong clinical recommendation from the panel that was operational at the time, and that was a universal decision.
A slightly different topic. You said in your statement that there should be universally available FibroScan technology as part of the operational delivery networks. In oral evidence, the hepatitis expert group described access to FibroScan technology as patchy. What's your understanding of the situation?
When we started the networks, we made available to every network funding for a FibroScan. So every network had a FibroScan provided. The demand and supply has increased dramatically. I think that the supply of FibroScans as a tool is, as you quite rightly say, patchy, but I believe there are sufficient alternatives to FibroScan that are now available. So, for example, there are blood tests. There's a simple APRI scoring system that gives a very good indication of whether patients have cirrhosis. There is a enhanced liver function test, an ELF test that can be requested. So there are blood tests that can be used to exclude cirrhosis. So whilst I agree that fibroscanning is not as widely available as perhaps I would like, I think that there are sufficient modalities of investigation to exclude cirrhosis in patients, and I think those are sufficiently widespread. I think it would be very unusual for a patient not to have an opportunity to have some form of liver fibrosis assessment.
Now, this is a question you may not be able to assist us with, but I've been asked to ask you, in terms of further research, do you think there is a need for further work to be undertaken on the needs of those infected by blood and blood products, particularly in terms of the longer-term impacts of treatments they've received in the past?
I've a long-standing concern about the long-term impact of interferon-based treatments on individuals. Published some research looking at its impact on psychological health. So I think I have to answer that yes, there is a need to look at the long-term impact of interferon and the other treatments. We know some of the first-generation oral antivirals, telaprevir, boceprevir, were particularly toxic drugs. So I would certainly agree there is a need for evidence to assess their long-term impact of those. I think we still do not genuinely know the lifetime impact of hepatitis C infection because, unfortunately, not too many people have died from it. And there may well be other consequences that will manifest in the distant future as a result of those treatments that we deployed. So I think it's certainly a reasonable research proposal. I have to say, have any evidence at the moment that we are seeing any long-term effects of interferon, telaprevir, boceprevir, but it would be perfectly reasonable to look into it.
Thank you. Professor Dillon, you are a consultant hepatologist and gastroenterologist with NHS Tayside, and also the clinical lead for hepatitis C for them.
Yeah.
And you're attending today on behalf of the Scottish Health Boards.
I am.
What can you tell us about your involvement in the hepatitis C work in Scotland?
So since 2009, Scotland, each health board has been mandated by the Scottish Government to have a clinical lead for hepatitis, and I've been NHS Tayside's clinical lead. The clinical leads for those health boards meet together 2 or 3 times a year to discuss strategic policy across hepatitis C and to respond to whatever diktats we receive from the Department of Health in Scotland as to what we should be doing. So that process and that structure has continued since then.
And as in 2006, the hepatitis C action plan phase 1 in Scotland was implemented, and in 2008 phase 2 was implemented. Could we just turn to WITN 4062002, please? This is the proposal approved by the Scottish Government in July 2019, the Action Plan Achievements and Proposals. And if we turn to page 3, please, Lawrence. We see in 2008 2008, just at the bottom of the page, there's a timeline. And in 2008, it indicates that there was serious investment, approximately £15 million per year of additional dedicated funding for education, awareness raising, prevention, diagnosis and treatment care services, and for coordination, monitoring and research, and the introduction of hepatitis C treatment targets. What can you tell us about that block of funding that was started in 2008?
So that was distributed to each health board to fund additional staff and resources and treatment costs to start to increase the numbers of patients being treated for hepatitis C using interferon-based regimes. So each health board made its own decisions as to what it should do. It was mandated to have an executive lead on the board responsible for hepatitis C and a clinical lead, and it led to the funding of several nursing posts in each health board to facilitate treatment for hepatitis C and pay for those treatment costs. And FibroScan machines, as Professor Foster has alluded to, already became part of that development as well, in terms of being able to stage patients, in terms of, in those days, treating patients with cirrhosis with interferon-based therapies was somewhat risky, so rather than prioritising patients for treatment, we were finding the patients we couldn't treat with those investments. So that was that money. Some of it was recurring and has become part of the each health board's infrastructure.
And in terms of identifying those who were at risk of being infected with hepatitis C, finding the patients, what work took place at that point?
So at that point, there was a rolling out of dry blood spot testing to make testing easier. So instead of having to take venipuncture blood, a drop of blood from a finger spot could be used to make the diagnosis of hepatitis C, sent to the lab and processed in the usual way. But it meant that people were much closer to a test, in terms of, rather than having to find someone who could do venipuncture, we trained large numbers of people who could do dry blood spot testing in the environment where the person who was at risk was located. There was a series of look-back exercises conducted at that stage around blood transfusion, awareness raising amongst general practice. Signed guidelines were developed recommending who should be tested and listing the risk factors at that stage, and those were promulgated through joint meetings with general practitioner colleagues, other general medical colleagues, and generally trying to raise awareness around hepatitis C and use that opportunistic testing. The action plan also took over the previously research-based database across Scotland for hepatitis C, which gave us everyone who'd ever had a positive diagnosis for hepatitis C in Scotland. And so their healthcare records could be followed, and the health boards were then aware of who was in their territory and who they had to be responsible for. We've never had the overarching strategies of England. Each health board has made its own decisions. We don't have an NHS England equivalent in Scotland, and so each health board makes its decisions. Now, clearly, we have a geographical issue in Scotland. We have 14 health boards. 4 of them are large, urban-based territories. 3 are medium-sized with some significant conurbations in them, but lots of rural things, and 7 are very rural with a very, very different complexion. So hepatitis C poses different challenges in each of those environments.
And if we turn the page and continue the timeline, we can see there the questions of the Penrose report and its recommendations, and then in 2019, the Scottish Government launches its hepatitis C elimination strategy. And if we turn the page, we have some data. Achievements include, between 2006 and 2018, a 45% reduction in the number of people living with chronic hepatitis C, from an estimated 38,000 to 21,000. A 55% reduction in the number of people unaware of their infection, from 23,500 to 10,500, and then a figure in relation to those who have cleared their virus. And then in the context of the era of the direct-acting antiviral therapies available since 2014, new presentations of hepatitis C related decompensated cirrhosis, liver failure, declining 67% from a peak of 141 in 2013 to 47 in 2018. New presentations of hepatitis C-related hepatocellular carcinoma, declining 69% from a peak of 58 in 2016 to 18 in 2018. hepatitis C related deaths declining 49% from a peak of 67 in 2015 to 34 in 2018. There is then the strategy proposed that's dealt with. Sorry, sir, it's just been indicated to me that the Northern Irish link appears to have just gone down. We've lost
Yes.
Dr. McLean.
I don't know if that's got anything to do with putting the document up on screen, but
I wonder if we should just pause for a moment and establish whether Dr. McLean can hear us.
we're
at least.
pretty close to the
We
time
are.
we would normally have a break, so perhaps this should be, albeit forced upon us, an early break.
Absolutely, sir. I was going to deal with the document and then suggest a break, but perhaps we can take the break now instead.
Well, let's do that and then come back to the document. So we'll take a break now until 20 to 12, and hope that when we come back we will have full function from Northern Ireland restored.